Assalamu alaikum. Hi everyone.
وعليكم السلام
Tell us.
دكتور مان. أهلا وسهلا.
Okay, sorry for the inconvenience. Uh, Hi everyone. I'm happy to be here with Sama in this essential sessions about the real disease focused on cholera in order to improve the response to the outbreak. I'm going to talk today about two interventions about cholera control. The first one is oral rehydration therapy focused on oral rehydration points, and the second one is oral cholera vaccine, which is abbreviated as OCP. Uh, just give me 7 seconds to share with you my PowerPoint. I know in the last session we covered the epidemiology of cholera and part of the case management. So the major problem of cholera is the dehydration due to the diarrhea, because every symptomatic patient have diarrhea, which is watery diarrhea, large amount, sometimes associated with vomiting. This lead to dehydration, which might lead to death. Case fatality is high when there is no controls. Okay, I will mute my mic until the azan. صدق الحق. Let's go to the session. I'm covering these topics as follows. I will start with background, then global situation, followed by Sudan situation, with examples from real situations, sharing our experience in fighting cholera. I started my talk about the fatality rate, which might reach 50% if there is no control measure applied. WHO aim to case fatality not to exceed 1%. But globally, in the last 3 years, since 2024, there is a surge in cholera cases. For example, 2024, uh, 33 countries reported cases and cholera all across the world, except one region, Western Pacific. Uh, if we take a particular example, November 2024, when compared to November 2023, there is increase by 37 and 27 in cases and deaths. Just 1 month, this increase, as you see here. Uh, Cholera spread is affected by many factors, whether it's man-made or natural. They share that there is poor access to safe water and poor hygiene. Uh, Cross-border dynamics have make it difficult to control the outbreaks. We have 47 countries where cholera is endemic. The transmission between countries occurs, especially in Africa and South Asia. I would like to let you know how things works in Ministry of Health as a background of cholera. This is the dashboard for cholera. This is 2 years, 2024, 2025, up to this 10 week of March. 10 March. As you see here, figures. I would like to highlight that your efforts, you see, these figures all are brought by you as frontliners working in the ground. We transform the data in the files into what we call it line list. Let's start with the first figures here. The cumulative cases, about 60,000. The attack rate is 180. And the outbreak in the last 15 months affected 12 states, 88 localities, with case fatality 2.6, which exceeds WHO standard, which is 1%. And you see the case distribution by gender, it's 50-50. Even the death is similar. And we use either RDTs or PCR according to the situation, but the golden standard is the PCR to confirm the outbreak. When we have positive RDTs or rapid diagnostic test, it's a probable case. Uh, you can see here the distribution of the cholera cases by age groups. The dark green here represent 20 to 30 years, which is 18%, because they somehow reckless regarding taking safe water, unsafe water. But unfortunately, the fatality is also high among this group, although they don't have any comorbidities or risk factors. You see here the disease in the community is 120, and the largest disease reported in health facility, which is about 1,400. You see this figure because we have weakness in the community surveillance. But this is so sad because it is 2.6 case fatality rate, and we aim to reach 1%. The outbreak started in August 2024 and didn't stop yet. As you see in the bar chart down there, the outbreak is going since August. I would like you to see the last outbreak in white line. You see here just 2 weeks the cases rise because the militia attack the power plant, so lead to electricity shortage, which affected the provision of safe water. The case fatality is 2.2, unfortunately. We aim to reduce it to 1% through different interventions. As a background, also, I would like to talk about the Global Task Force for Cholera Control. As you see the logo here, let's see who are they and what they plan to do in the next years. Uh, Global Task Force is a global partnership of more than 50 institutes. As you see here, logos, some you know, some you don't know. For example, Gavi, ICRC, Rescue, Oxfam, and WHO is presented as Undersecretary for this group as rapporteur. They aim to end cholera. Simply, the vision is to end cholera, and they support countries to implement measures to end cholera, and we can see their objectives through these pillars. They are committed to support national cholera plans in countries uh, through early detection and multi-sectoral and well-coordinated intervention. They aim to eliminate cholera from 20 countries and stop catastrophic outbreaks in fragile setting and developing countries. 2030, the ultimate goal is to reduce the fatality by 90%, which is for us it's preventable because most of them due to dehydration. To reach this goal, there is an intervention to be implemented, starting with WASH, water and sanitation and hygiene, and surveillance and reporting, and using of the OCB as a measurement, uh, and strengthening health system. And our first topic is about oral cholera, oral rehydration points, which is sub for case management, which is part of health system strengthening. Leadership and coordination is essential uh, to manage this all efforts to end cholera. Always community participation is part of our interventions, so we could improve the uh, provision and uptake of our vaccines and all these intervention to be accepted by the community. Let's talk about our first topic, which is oral hydration point as part of the oral rehydration therapy. Oral hydration point is a point of entry at community level or even at the health facility level to treat and refer acute watery diarrhea or cholera cases, because at the community it's be like watery diarrhea, not confirmed as cholera cases. The ORB should be visible with a poster or something to guide the patient who experienced diarrhea to be treated there. The working time is daylight through all over the week, and to handle these cases at the community level. Importantly, staff of the ORP provide the ORS or oral hydration solution as per treatment protocol, aiming to prevent the dehydration. Why to set ORP? This question, because as you know that the health seeking behavior affect the uptake and consumption of health services. But particularly in cholera, the stigmatization and discrimination around cholera may make families to hide their symptoms, so delaying their presentation and receiving the proper treatment lead to a preventable death. Or RB also can reduce the pressure on cholera treating centers or units, CTC or CTU, by treating simple cases at the ORB instead of going to the CTCs and CTUs. I would like here to give you a overview about the case management of cholera. We have a triage for the patients, starting as severe dehydration, some dehydration, and no dehydration. Severe dehydration patient has features of shock, lethargic, unconscious, or have two of the signs like sunken eyes, skin pinch very slowly. Any of these criteria make this patient as plan C, as a severe case, and this need to be admitted to the CTC or CPU. Some dehydration is the next level, and there is no danger signs of dehydration, but still the patient has signs of dehydration. The patient might become irritable, sunken eyes, rapid pulse, and this, and this classified as LAMB and need to be admitted to the CTC CTU. The difference between CTC and CTU is the CTC is smaller and in bed capacity staff, and sometimes it can be seated outside in rural areas, and the CTC will be held on the urban areas and city centers. The last category is no hydration, which you have a patient who presented with watery diarrhea, but he's awake, talking to you, normal stress, and the skin pinch is normal. This is the main target for the ORB. But as you know, oral rehydration therapy is part of all these levels because it's complementary to the IV fluid in Plan C, and also Plan B. It's all about rehydration through ORS. Let's go deep in setting ORBs. ORBs it's a multi-sectoral approach. Need risk communication and community engagement, surveillance and case management as part of this ORB because it's interconnected. The number of cases visiting ORB will be reported to the Ministry of Health with their basic information, and the case management and the severity of cases presented to the ORB also will be documented, and this data will shape the intervention. For example, we might add another ORB, we might add or build CTU around near to the ORB, all interventions based on this data. To set up an ORB, we need access to the safe water and good sanitation and latrines to prevent ORBs being a source of infection. The site of the ORB, based on the data as I spoke before, the site of these ORBs will be guided by the medical data and the community consultation and their acceptance because uh, we need health promotion and community engagement to set up an ORB. ORB can be temporary or permanent part of facility or social club. There is no problem. It can be fixed or mobile, no problem. The aim is to provide RS to the patient, preventing the dehydration. Regarding the staff of the ORP, healthcare workers, if available, it's okay, community health worker, nurse, to be responsible of the ORP or using the volunteers from the community. We need to conduct training session about the ORS preparation and dosage and basic health education message about WASH, for example. Uh, we have a patient registration sheet, as I spoke before, provide the data of the patient, and whenever possible, the staff of the ORB should be from the community as part of their participation, and they are acceptable to them. Additional staff to support the focal person of the ORB as volunteers will be good. I would like to confirm that ORB is part of the response under the title of case management. So there is a clear pathway for repairing severe cases. Not all cases presented to the ORB will be simple, but we have some cases, some dehydration and severe dehydration. We need to stabilize them and then refer them to the designated isolation centers. Most importantly, the supply sustainability. We don't need any stock out. The support, uh, the sponsor body, for example, UNICEF or any organization with the Ministry of Health maintain a sustainable supply, and also they have a contingency budget for any emergencies. ORB will. It's better to be set in the early start of the outbreak until the end of the outbreak, and the places can be changed according to the numerical data to guide the interventions. Regarding preparation of ORS, as you know, there is a sachet. The UNICEF provide free ORS, but regarding preparation, uh, every single sachet has his own quantity. So usually one sachet for 1 liter for one sachet. The ORS provide potassium and sodium and glucose to the patient as rehydration. It's not only for cholera, it's for all diarrheal disease. Uh, RS should be prepared daily, and it's for 12 hours if in the room temperature, and it may be used for 24 hours if kept in the refrigerator. Also, there is oral rehydration solution made at home. It's okay. This can be part of the health education message to the community, but at ORP we use the prepared ORS to be provided to the patient. Regarding the dosage of ORS quantity, we have patients with diarrhea. So we would like to correct, to prevent the dehydration. They are not presented with dehydration, but the frequent stools or motion lead to the dehydration. For the children below 2 years, 50 to 100 ml after each loose stool. Total amount per day is 500 ml. And for children above 2 and below 10 years, under 10 years, 100 ml, 100 to 200 ml after each loose stool. The total day is 1,000. And for 10 years and above, an adult 200 to 400 ml after each loose stool, approximately 2,000 liters, 2,000 mils, 2 liters, I mean. We need to stabilize the severe cases before referring them. Maximum amount of time spent in the ORB is 4 hours. Otherwise, patient has to be referred to the CTC or CTUs. I would like here to give you some examples of setting an ORB in Sudan. For example, in 2023, MSF has established an ORB in the prison. We got many patients from prison in the Medina CTC. As part of the response health education session, an ORB were conducted in the prison. Also in 2024, MSF set up for ORBs in Kassala. WHO has sponsored 45 ORBs. This almost half of the functioning ORBs all over the country. And finally, I would like to share with you experience of Al-Khatmiya ORB, which is sponsored by UNICEF as part of 43 ORBs. As you see in the photo here, Ismail is a community health care worker who offered his home to be an ORB And as you see here, the patients come to the center experiencing diarrhea. This is the example of dedication to serve humanity and saving life, not only as volunteer, but also as healthcare worker professional who dedicated his home and time to participate in the response in the cholera outbreak. Additionally, Ismail has made home visits to the very ill patient to improve their rehydration status. Uh, this will help to reduce the level of dehydration, and accordingly, they will be treated either at home or referred to the CTUs or CDCs. Here is another photo, Ismail giving ORS to a child, and right photo, you see the ORS, and I would like to confirm the role of the Minister of Health in monitoring the ORBs. You see here there is a sheet registry in the corner, right corner below. This registry registers the patient as part of the surveillance. By this photos, I came to end of the first session about the ORB. Now we would like to go to the OCB. OCB or oral cholera vaccine. You see here the photo in Iraq, WHO staff participating in the OCB campaign. WHO recommends using OCB as additional measures to limit the spread of the cholera, especially during humanitarian crisis and in areas where cholera is endemic. We have two campaigns, either reactive or preventive. Reactive when you have an outbreak, preventive when you have endemic disease and you anticipate cases of cholera, especially in autumn or after flooding. So WHO established a stockpile for OCB in 2023, and we have what we call international coordination group, which is responsible to receive requests for OCV campaigns, whether it's preventive or reactive. This request has to fill some criteria, which is essential. At least one single positive case with PCR to confirm the outbreak there in the reactive campaigns. And they go deep with the Minister of Health to assess their capacity in the cold chain. So if you request special amount of OCB doses, you have to have enough capacity in the cold chain. Uh, we would like many, as much as people who are eligible to receive the OCV and to be conducted as soon as possible, especially during the outbreak, as an intervention to minimize the spread of the outbreak. It works within 2 weeks, and the slope of the outbreak will drop. WHO pre-qualified three types of or OCVs. We use here UV called plus, from cholera, and started OCVs in 2019. At that time, first time to declare cholera outbreak. Dr. Akram was Veteran Ministry of Health at that time. And since that time, we conduct many OCV campaigns. All OCVs are oral. We call it oral cholera vaccine. All of them, the three companies or three brands, are oral, and they are killed. They provide protection with 60% in endemic areas, and it might reach 30 years for the two doses. The one dose provides short-term protection, like 6 months only, but it has important role to control outbreaks. Since 2022, due to the cholera surge, there is a demand on OCP. So WHO, through the ICG, decided to stop two doses intervention campaigns and use one dose campaigns uh, to due to the shortage of the OCP and to the surge in the cholera cases. They prefer to cover more countries in order to improve the overall response to cholera and reduce fatalities. Uh, the vaccine OCV, for example, UV call plus, is used as a two doses with separation at least 14 days up to 1 month, and there is no contraindication for OCV except children below 1 years. It's given to anyone, regardless the age, regardless the gender, pregnant, non-pregnant, HIV positive. There is no contraindication for OCV, and the common side effect is fatigue, abdominal pain, nausea, and diarrhea. Okay, let's see what is going on globally regarding the OCV, and you can imagine the high demand. Uh, Up to February 2025, the OCV dashboard received about 240 requests. 200 was approved, and more than 200 million 15 doses was shipped to the countries. Uh, 32 countries out of 35 countries, and the average decision time for the OCV request is 13 days. I would like you to see the demand through the last 10 years. As you see here, since 2022 up to 2024, you see this share. In 2022, it was 23 requests. In 2023, it was 28. And in 2024, it was 36. For the last 3 months or the first quarter of 2025, there were 13 requests. So if we go with this trend, might reach almost 50 requests in 2025. And you can see the distribution of these campaigns in Africa and in South Asia. This is the map up to February 2025. Cholera is strongly related to the developing countries because of the poor infrastructure and poor hygiene. Regarding Sudan, as I spoke before, started in 2029 in two states, in Nara and Blue Nile, with cumulative coverage because it was two doses campaign. The cumulative coverage was 98 and 85 for Sinnar and Blue Nile, respectively. Since 2023, after the crisis, 15 April crisis, the cholera outbreak starts and covered almost all states in in Sudan, except Darfur State because it's out of surveillance. I don't know what's going on in most of Darfur states and some Kurdistan states. But we implemented huge OCP campaigns. We covered 25 localities in the last 2 years, and the coverage or the uptake rate in some localities reach 100%, and the cumulative response is like 78 or something like this. And you see here in the photo, this is from Kosti, the last OCP campaign, targeting 1 million people in Rabat and Kosti. Finally, I would like to share part of our experience regarding OCP. We have unpublished paper about cholera and OCP in Gadarif locality. The first one was among internally displaced persons. We conducted a cross-sectional community-based survey from 15 call it gathering centers for IDBs. Majority of the participants took the OCV, and there was significant association between the knowledge score about cholera and formal education and hand washing. The participants who didn't treat their water had two wise odds of not taking the vaccine. The main reasons for those who didn't take the OCB were the lack of knowledge about the OCB and the fear of side effect. Many of the IDPs goes to work because they don't have money. In the morning, they go to work within the Darif city or outside, and they came later at the end of the day. The OCB uptake was high, 83%, but it's still lower than the overall or cumulative response rate in the Gadarif state. The study recommends to continue using health education session and home visit as health promotion tools for prevention and control of cholera outbreak, and also to improve the outcome, the uptake of OCVs. The second study was conducted among healthcare workers targeting nurses and doctors in 12 public hospitals in Gadarif locality. Uh, Unfortunately, the uptake was lower than the IDBs and the community. It was 56%. And the primary barrier for the healthcare worker is the fear of adverse effect. And the next slide, you see a healthcare worker in CTC. I talked to some of them. They said we see patient came to the CTC with the area after they received the OCV. So they get anxious about getting the area after receiving the OCV, although the side effects are very minimum, nausea and abdominal pain and the area. The multivariate analysis or study showed that participants who didn't attend the orientation session or training on cholera were less likely to receive the vaccine, and the odds of vaccine were also significantly lower among the medical doctors compared to nurses. The study recommends interventions targeting healthcare work, including training session and health education to enhance healthcare worker awareness about the OCV and side effects. Uh, Finally, I would like you to get the most important points about these topics. Two topics. Successful ORPs and OCB campaign needs a multi-sectoral and well-coordinated efforts. Community engagement is essential for both ORP and OCB campaigns. ORB aims to treat simple cholera cases and reduce the pressure on CTC and CTUs, and also to stabilize the severe cases and then refer it to the designated CTC and CTUs. OCB should not disturb the provision of the high priority intervention to control the cholera, especially WASH intervention, because it's not only about giving them the OCD. By this slide, I came to end and would like to show you some references here. National Surveillance Board and WHO website, UNICEF, and GTFC website. Uh, Thank you so much. And if you have any question or comments, you are welcome.